Morning, everyone. Today I will be presenting a case of atypical meningioma, which is the 400th case of meningioma reported at Shanti Pathology Laboratory. A 66-year-old lady presented with complaints of headache and seizures. She had been operated for right frontal meningioma in 2016. Her MRI revealed a craniotomy defect on the right side and a well-defined extra-axial lesion in the right parietal lobe that measured 5.1 into 3.6 into 3.4 centimeters. It was hyperintense on T2 and flare and T1 showed hypointensity. Vasogenic edema was present. The lesion showed restriction diffusion. Post-gadolinium study showed intense homogeneous enhancement. So this was a case of recurrent meningioma. We received a single irregular gray white firm tumor measuring 5.5 into 4 into 3 centimeters. Cut section revealed firm gray white areas. Now one must remember, when we get such a tumor in lab, multiple sections should be taken from periphery of the tumor just to look for the brain invasion. We studied multiple slides, and a tumor composed of neoplastic meningothelial cells arranged in syncytia sheets and whorls was seen. The meningothelial cells were round to oval, and they had round to oval delicate vesicular nuclei with inconspicuous nucleoli and moderate amount of pale to eosinophilic cytoplasm. Nuclear pseudo-inclusions were seen. There were some foci which showed increased cellularity, and there were sheets of these cells. Mitotic activity was increased, that is 5 to 6 per 10 high power field was studied in the consecutive sections, consecutive foci. Spontaneous necrosis was noted. The intervening stroma showed extensive areas of fibrosis, increased vascularity, and variable hyalinization of the blood vessels. Few Samoma bodies were seen, and the brain invasion was noted at multiple foci. Now one must see that this brain invasion should be in form of tongue-like protrusions into the brain parenchyma. So you can see these slides. There are multiple foci of tongue-like protrusions into the brain parenchyma. You can see these structures here, foci of spontaneous necrosis, and increased mitotic activity was noted. You can see these are typical mitotic figures. So we rendered a diagnosis of atypical meningioma, CNS WHO grade 2. The term meningioma was first introduced by Harvey Cushing, a renowned American neurosurgeon, in 1992. He is also known for his work in the pituitary adenomas and the Cushing syndrome. Meningiomas affects the adults mainly, and the mean age group is 65 years. Women are most commonly affected, and 66% of cerebral meningiomas and 90% of spinal meningiomas occur in women. When they rarely do they occur in the pediatric population, and they are typically associated with genetic syndromes or childhood radiation. These are extraaxial masses which grow along the external surface of the brain and the spinal cord, and rarely they grow within the ventricle, that is, we call it intraventricular meningiomas, and rarely they may be found outside the CNS, that is, they may be ectopic, or we call them primary extradural meningiomas. So the common CNS sites are cerebral convexity, skull base, the fox tentorium, and the spinal cord. The primary extradural meningiomas, most commonly the site is head and neck, that is, it also affects the scalp skin. It may be intraosseous, orbital, affect the paranasal sinuses, ear, and the temporal lobe. Rarely these cases may be found in lung, salivary glands. Now, atypical and anaplastic meningiomas, they most commonly occur at the cerebral convexities and other non-skull-based sites. Anaplastic meningiomas metastasize may metastasize to lung, pleura, bone, or the liver. Coming to imaging findings, meningiomas are sharply circumscribed spherical or lobulated extraaxial masses with broad dural attachment. Intact meningiomas are flatter, carpet-like lesions that infiltrate the dura. Cortical buckling is noted. A distinct cleft of arachnoid with trapped CSF and prominent vessels that surround the extraaxial mass is often observed. Calcification, necrosis, cyst, and hemorrhage may be found. Hyperostosis of adjacent calvarial bone and irregular cortex can be seen. On T1 and T2 images, meningiomas appear iso to hypointense with the cortex. The T1 images are best to visualize the gray matter buckling, and the T2 weighted images are best to visualize the trapped CSF clefts and the vascular flow. Post contrast, T1 images show intense homogeneous enhancement. Dural tail sign is seen in most of the cases of meningiomas. However, it is not specific for meningiomas. So this is another case. You can see this is a left sylvian fissure tumor, and you can see very nice dural tail sign. WHO CNS5 has mentioned 15 subtypes of meningiomas, which have been categorized into 3 grades. The CNS WHO grade 1 includes meningothelial meningioma, fibrous meningioma, transitional meningioma, psammomatous, angiomatous, microcystic, secretory, lymphoplasmacyte-rich meningioma, and metaplastic meningioma. Under the grade 2 are chordoid meningioma, clear cell meningioma, and atypical meningioma. Under CNS WHO grade 3 are the papillary meningioma, rhabdoid meningioma, and anaplastic meningioma. The terminology anaplastic has been omitted by the new WHO for most of the tumors, that is oligodendroglioma or ependymoma. And now we should mention them as oligodendroglioma CNS WHO grade 3 or ependymoma CNS WHO grade 3, whereas the term anaplastic has been retained in case of meningiomas. So coming to grade 2 meningiomas, the mitotic activity is should range between 4 to 19 mitotic figures in 10 consecutive high power fields, or unequivocal brain invasion should be present, or it should have the specific morphological subtype, that is chordoid or clear cell type of meningiomas, or at least 3 of the following, that is increased cellularity, small cells with high nucleocytoplasmic ratio, sheeting, that is uninterrupted patternless or sheet-like growth, and foci of spontaneous necrosis should be there. For the grade 3, 20 or more mitotic figures in 10 consecutive high power fields should be noted, or frank anaplasia. The histology should be that of a sarcoma, carcinoma, or melanoma-like appearance, or they must show TERT promoter mutations, or homozygous deletion of CDKN2A or B should be noted. Coming to immunohistochemistry, somatostatin receptor 2A is the specific marker for meningioma. EMA is positive. It is usually patchy and not diffuse. And the progesterone receptors, these show strong nuclear positivity in low-grade meningiomas and diminished in high-grade meningiomas. Let us have a look at the differential diagnosis and the markers utilized for the same. GFAP is used in highlighting the entrapped brain in cases where there is a dilemma of brain invasion. It also helps us to differentiate chordoid meningioma, which is negative for GFAP, from the chordoid glioma, which is positive. The chordoid gliomas also express TTF1. Second tumor is the chordoma, which is brachyury positive, and the chordoid meningioma is negative for brachyury. STAT6 is useful to distinguish meningioma from solitary fibrous tumor. Inhibin differentiates angiomatous or microcystic meningiomas from hemangioblastomas. Now, SOX10 helps us to differentiate fibrous meningiomas in which it is negative, and schwannomas shows strong positivity for SOX10. A dilemma may arise in a case of CP angle tumor. Now, most of the tumors arising at the CP angle are schwannomas. However, sometimes the meningiomas at this location may have fibrous histology, which makes it difficult to distinguish. So, one can utilize SOX10 in such cases to which is a significant, which is specific for schwannomas, and it is negative for meningiomas. There's one more point to remember, that the fibrous meningiomas may also express S100 positivity in 33% of cases. So one can also utilize somatostatin receptor 2A, which is a specific marker for meningioma. Coming to molecular features, meningiomas associated with TERT promoter mutations, intragenic deletions in dystrophic encoding and muscular dystrophy associated BMD gene are associated with higher rate of malignant transformation, shorter time of recurrence, and lower survival rate. Inactivation of BAP1 in rhabdoid tumors is associated with shorter time of recurrence. The BPRM1 mutation in papillary meningiomas is associated with aggressive behavior. CDKN2A-B alterations show recurrent tumor and poor prognosis. Coming to prognosis and prediction, grade 1 meningiomas have recurrence rate of about 7 to 25%. Grade 2 meningiomas recur in 29 to 52% of cases, and grade 3 meningiomas recur in 50 to 94% of cases. The treatment is usually surgical excision. If there is incomplete resection or atypical or anaplastic subtype of the meningioma, then radiotherapy is considered, and radiation has been shown to improve local control and prolongs overall survival. If you like the cases I am presenting for you, do subscribe my channel and share my cases. Thank you very much.